Case number 8, we have a TAVR of a 79-year-old male who has a history of exertional dyspnea, but if you see patient has paroxysmal AFib on hemodialysis, COPD, history of peripheral vascular disease, and in the past what he did have multiple PCIs, but also a BAV when he was pre-op for a AV fistula. So that was way back in December. Since then, now he's symptomatic, so he's back here for a TAVR. So what we are going, as you see there, we're going to show you the echo quickly, and then the CT scan. Next slide. This is the echo which confirms that patient has a significant aortic stenosis. Show the CT scan. Next.
Wow.
Good afternoon. So you can see there's a lot of calcium in the aorta, ascending arch. The annular plane is fairly vertical, so not challenging at all in terms of horizontal aorta. Next slide. Next. You can see here's our annulus. The annulus itself has a few spicules of calcium there at about 12 o'clock and 6 p.m., but nowhere near like the calcium we had in the last patient. Area is 5.4, which puts it in the range for a 26 SAPIEN-3 valve. Next slide. You can see here the LVOT are reasonably generous at around 5.8 centimetres. Next. Sinus of Valsalva, again, generous, not a problem, around 30 to 32. Next. Coronary heights, the left is about 13, right about 12, so not a concern here for the coronary heights.
So you, JK, what is the coronary height that you think we should be concerned? Tell us about that.
We usually get worried at around, it's a combination of multiple factors, including the coronary height, the length of the left leaflet of the aortic valve, and also the width of the sinus of Valsalva. But less than 12 is where we're getting concerned. This is a left main of about 13 millimetres with reasonably generous sinuses of Valsalva, so it shouldn't be a problem or a concern for left main coronary occlusion.
So that's where we are. If you have a low height and you have a small sinus of Valsalva and your leaflet is probably long, that's when you think that could be acute obstruction of the left main.
Agreed.
Yeah,
absolutely.
But you don't have to worry.
Waxman?
No, I just have one question. Do you have any surgeon in the room right now?
We have Alan Stewart.
Alan Stewart's right here.
Alan Stewart is our cardiothoracic surgeon.
So you keep a surgeon in the room?
Always, in every case.
And is there any reason why you choose one valve versus the other in this case, or you just want to even out because we saw before Evolut Pro and now we want to see something else?
I think this very good point. There's obviously some patients are better suited to one or the other. I think this is an anatomy that could have happily gone in either direction with either valve.
Yeah, I think a more important point which Ron Waxman pointed. If we have this kind of borderline left main cases, we definitely, if the vasculature is suitable. I think I would say two things. The vasculature has to be suitable since the sheath size is still bigger for a SAPIEN compared to the Evolute, not Pro, the regular Evolute. Evolute Pro has gone back to 18, otherwise just Evolute would be 14 French sheath. Other than that, if you have a low coronary height and we think there will be likely obstruction of coronaries and we have to protect it with a guide and a stent in the vessel, that's the time you would go for SAPIEN versus otherwise Evolute. Yeah, and the valve in valve, I think we will favor more of Evolute.
The data is clear for Evolute in that situation.
So a patient like this, you're going to show us what you do. We're going to watch you. More importantly is that this is an end-stage renal disease patient on hemodialysis and also atrial fibrillation. Will you send this patient home on warfarin or on a novel or oral anticoagulant, and for how long, and what do you do there? How do you balance the bleeding and everything else?
Now, patient has already been on Coumadin, in which case we will just continue on Coumadin. Otherwise, of course, we have your trial going on where we are randomizing patients to Novak versus aspirin Plavix.
Yeah, okay.
The next slide.
Yeah,
great.
Next slide. You can see the access. The patient does have PVD and has had previous PTAs before, but the access is reasonable. We've gone up the right side with the main sheath. Next slide. Next slide. Here you can see fairly straight. There's some spotty calcium, but nothing too problematic. Next slide. And here you can see the valve selection according to the size of the annulus and other considerations. It's a clear 26 millimetre S3 valve. Next slide. So the case, we've really already summarised it thus far, so I think we can just move right ahead.
Yeah. And one other thing that since we have the Sentinel approval, every case, especially this one, you saw the arch, a heavy calcium, lot of atheroma in the arch, that if suitable anatomy, especially you know your arch in the CT scan, we will be able to get the Sentinel device that we will be using Sentinel in many of these cases. Same thing, you don't cross the valve. We have the Sentinel here ready that we are going to go up with the radial. We went with a 300 Grand Slam.
So this is great. So you're going to do a neuroprotection here, is that
Yes,
correct?
Exactly.
Yes.
So let's hear from the panel. The Sentinel device is a neuroprotective device, a double filter. Maybe our crew could put it up so people could see on one of the screens.
They should show in the factoids the Sentinel.
Yeah, they can show us that. Very important, it comes from the radial side. It's a dual filter, covers...
If you see here, now I'm in the right brachiocephalic artery, and you can see the filter. You have two filters, one at the distal and one in the proximal.
That's right.
So the proximal is the one that will be deployed in the brachiocephalic. Do you see that? Let me go.
Yeah, we see it, and I'll show it.
Yes. So I'm just going to go way further down. Now you see the distal filter. So you need to give about a centimeter gap from the ostium of the origin of the brachiocephalic. Is right there. And it's all nicely marked, if you can show here.
It's very simple. As you're going to see very, very quickly, Dr. Kini is going to put that filter up.
Probably go a bit further, see the pigtail of the aorta.
And if you're not sure, you have the pigtail there, you can take a picture. But I think this is very straightforward.
What's nice about it is that you actually don't need too much to give more extra dye. You'll see here. So
now I'm going to pull what they have marked, number 1, which means the proximal filter is going to be deployed, if you can watch that.
Here goes the proximal filter.
Yeah, it's coming out.
Here it comes. You see that?
So after that, what you do is you hold your left hand right at the proximal filter, and then I'm going to pull back. If you see, is number 2 now. So now I'll be working on number 2. I will just pull this back. We have to rotate it. JK is pulling the wire back, the distal tip of the wire I'm pulling. And as I reach here, I'm going to rotate, so it will now face to the
common carotid.
Yeah, left carotid.
Carotid.
You'll see it.
We can
advance a little bit more.
Here you go, and you see how nice.
Rotating.
And now you'll go up into that.
Let's have echo up, please.
The T is
Yeah,
in
go
in
take the
way.
T out of the way so we don't see it.
Yeah. Rotate a little bit more. Yeah.
And now she released the
Now
second
here she
filter.
is, and she's going to release that distal
So
filter.
now you went into the internal carotid, so we're just going to, the number 2 has done its job. You want to pull the pigtail down. Good. That's good, right?
And you see there's very little, and we're going to watch the interaction of the device to this.
We will advance the distal filter. You just see here, JK is holding the wire. I'm going to advance the filter here.
Here we go. And there goes that second filter.
And then you can pull back the wire a little bit, so you're not way deep in the internal carotid. It looks good, right?
Excellent.
Agree?
The whole system back a bit. Right?
So that just stays there, and it's really irrelevant, and hopefully with very little interaction with the devices as they come across the aorta.
Give us some wet towels.
In the Sentinel trial, there was a non-statistical significant, but a reduction in lesion volume in patients who had this. But in every case, there was collection of debris in the filter. So the device is now approved, and this is for these patients. And now you're going to go and do your job. You saw how simple that is. So
Roxana,
let's go to the panel. What does the panel think about neuroprotection? Yeah, Deepak.
Yeah, no, I was just I mean, it was beautifully deployed, and it seems like it was done with no risk to the patient, so I can't criticize anything about the technical aspects. But as far as the data, it was a negative trial, and even though intuitively it makes a lot of sense to do this, I always get a little nervous when a pivotal trial is negative and we're using something that brings some complexity to the procedure, some risk, especially in hands that aren't so experienced.
If you can show the hemodynamics,
So it does make me nervous, the
very
approval of the
good
device.
question, and we could kind of talk about this because it is. There's no question the trial was negative but there was a reduction, but it was negative. It didn't meet the statistical significance. Exactly correct. There was numeric reduction. It was an incredibly safe device, and a numerically reduction of stroke from 9 down to like 5%, or it was a good reduction in the stroke patients, but again, not statistic, wasn't powered for stroke. What does this panel think about the neuroprotection during TAVR? Ron Waxman, let's start with you.
I'm very happy that it was approved. However, the utilization, I think, or broad utilization needs to be more based on more data and more studies. We did learn that the MRI, DW is not a very reliable endpoint. We'd like to see some more hard endpoints. We'd like to see probably more data to generalize it. But often we do have cases like this one or others that we see in atheroma in the arch, and we feel that we know that there are distal embolization there. So I think we'll have to start to select patients, although again, nothing from the study shows us who are at risk. So I think Deepak was right. It's a little bit uncomfortable when you don't have the data, it's just by intuition. It's good to have it approved, but I think it's upon the sponsor to continue to study and give us some
more people, exactly.
Yeah, and
Mike?
actually, I think the point remains that at least we have a device.
There you are.
May not to be used in everybody, but some cases. As I showed in the data also, that clearly the issue remains that once your primary trial is negative, how do you do? But I'm sure the FDA still took it very positively. And they got approval. So in some cases, so people ask how many cases. Actually, we just had one of the media person called us that how many cases you think you'll use it. From my point of view, I think until we know a little more, probably 20%. I don't know, Ran and Deepak, maybe the number will be what? But that's what I feel.
There is also a cost issue. I mean, so we cannot ignore that part when we're struggling on the margin of profitability of doing TAVR. But I want to ask you, why did you do BAV? The gradient didn't seem to be that high there and not severe calcification. So, and you yet elected to do
it
BAV.
Because of high calcium? JK, what was the reason for BAV in this case?
So the patient had a BAV, but it was quite some time ago. That was done in preparation for the dialysis fistula. I agree there wasn't a lot of gradient, but the leaflets themselves had some calcium. So we generally tend to BAV our cases if there's, some equipoise.
Okay. Now,
I think there is more and more data that you can skip that step. I mean, it started with Eberhard, but I think also on S3. I mean, we doing it only when we have a high gradient or very calcified leaflets.
John,
Well, after today's discussion, we'll start doing less BAVs now.
Yeah, so we're just going up. So you have the loader cap through the valve.
John LaSala has a point, Dr. Kinney?
Yeah, just a couple
John?
caveats, too. Remember, these people are screened with their CT scan as to the appropriateness for the Sentinel device. So there's a lot of anatomies that are not as easy as this. They can be very challenging. I know on my anecdotal experience, it takes me sometimes as much as 25, 30 minutes to get it into position, particularly tortuous, calcified vessels coming through. Different types of aortic arches are more suitable than others. Some are completely excluded. So remember that these are screened ahead of time. And even though it's approved, and I agree with Ron, it's nice to have that approval, I'm not sure the general TAVR deployers are going to use this universally, and they might self-select certain high-risk populations for its application.
So now we are in the descending aorta. So what we are going to do is align the balloon and the valve. Just keep coming back. Keep coming back. Till you see that is a white marker. When you see the white marker, you stop, you lock it. Then you have the fine adjustment where you keep rotating counterclock till you get, and you see the tip of the balloon marker is right
inside of the valve.
You just unlock, lock.
Yeah, release the tension, that's important.
So at this time, the first operator will be advancing, and I'm just going to flex the wheel so the entire catheter bends. So we are going across the arch.
And see that it does not affect our Sentinel device.
Yeah,
So
that's
clearly
important. So you want to watch the travel on
You
the
watch
arch.
that there's no interaction or pulling on that device. And you see how nice it just
So
goes
completely
in.
flex.
And I think this is not
one of the
touching
advantages of
smaller
this device.
or greater arch of the aorta is really has been the factor with all the S3 showing the CVA rate of 1% or low.
Again, so what you need to do is now you unlock here, pull the flex catheter back completely so that your balloon is exposed. So
The
say
pusher,
you have
yeah.
3 markers, you come and stay at the center mark there. Lock it again so everything stays.
And just come off.
Where is your pigtail?
Just stay off. Yeah. Stay off.
Let's
Just
bring the
stay off.
pigtail.
Yeah, you have to
Now
bring
you
it.
get the
Angle, you haven't got the
pigtail.
angle yet, okay?
You have
Just
your
stay off
pigtail.
fluoro for a second because you have to put that. We're just finding back to our root angle for deployment, which is here. So it's LAO 10, no cranny.
Give me the wire for the pigtail. Many times, getting the pigtail will be very difficult here.
Okay, so we need to put a wire into the pigtail. And these patients with the peripheral disease, catheter gets so much kinked. So it's best is just put a wire back and as if you are advancing. Pull a little bit. No.
Get us
Wire.
a stiffer
It's a
wire.
stiff wire.
Sometimes
It's a
it's good to
sheath wire.
take the pigtail a little bit back to the descending and start to travel.
There you
Like
go.
now,
Yeah, we did that,
beautiful.
yeah.
There you go.
Good.
Counter it.
That's good enough.
There's a lot of tortuosity.
Yeah.
We see
Go,
the
go.
catheter down below.
May I ask, do you routinely use TEE now on all your procedures?
No. Not in every case.
And not every case
I would say
is-
30%
is,
we will use
is some conscious
transthoracic
sedation.
in the sense same that you finish the echocardiographer is around, and at the end of the case they'll just quickly do a transthoracic echo and tell us everything looks good.
Yeah, we've moved to doing predominantly transthoracic
Exactly.
and not TEE now.
Okay.
Do
Let's see
cut
where we
down,
are.
conscious sedation, no tea, and I think soon you don't need anesthesia in every case because you can
Okay.
actually give them Versed and
So,
fentanyl like a
Very
regular
important
case.
is you go at 180 and check the valve position same. You have the annular plane and your balloon dot has to be just at that annular plane. 180, okay guys? Go 180 pacing.
You want to first see where you are?
Yeah, probably you want to
Yes.
give.
And reason for pacing is your blood pressure has to be less than 40. So I think it looks good.
Yeah,
Everybody agrees?
yep.
Okay,
Yeah.
we're going up now. Pace 180.
She checked the pacer before,
Yes.
Roxana.
Yeah,
Make sure it's
she
working.
checked it, that it's working.
Now I know the blood pressure is 40. Slow.
It-
When we are halfway through, then you go full expansion.
Okay. You stop the pacing.
So one of the things that we're doing a step. So we inflate some, inject, and
Okay,
then if
good.
we
Stop
confirmed,
pacing.
then we go all the way.
And as coming out, you unflex it, leave it there. If echocardiographer is around, we quickly ask them if it looks good.
Yeah, actually, Ran, your point that a lot of people do, that inject while you are, I
AI
always
now.
felt that there multiple issues occurs then
Blood
at the
pressure.
time when you are deploying the valve and still giving the injection. So we will many times will pace, give the injection, make sure the valve does not move. If moves, then do it again. But at the time when deploying the valve, we're just not giving the dye at that time.
Is there AI on the, we see AI on the
No.
color. There
Dr.
a little-
Chaudhary looks good, right?
Yeah, we see mild paravalvular regurgitation.
Yeah. Mild is
So
okay.
even though this is not a self-expanding, sometimes it takes about 5 to 10 minutes and it's going away without any manipulation.
And also you have to, adjust your...
And take the wire out also
Wire
because you have a
little bit.
wire there,
Right.
so
Yeah.
that's also can interfere.
Okay, ready for the blood
Part of that's
pressure is
related to
good
the
now.
seal.
Blood pressure is picking up. Your systolic is just about 80, diastolic about 50. Okay, inject.
No,
I think
it
this
looks
is a beautiful
good.
result.
Is it a central
good.
probably?
That's a central.
I would do it without the wire. The wire is can
Okay,
mislead
we'll do
here.
it.
Take this.
If you need to cross, it's not a big deal to cross again.
Okay, do another aogram.
And I would wait about a minute before that, if you
Yeah.
have time.
Oh.
They're still here in
That's
AR.
acceptable. So if you check the hemodynamics, same diastolic just about 80 now, right?
Yep.
We're done.
I'll fix it. With a retrieval.
So now the last step remains the retrieval of this very, I would say that really what a mastery in terms of making the Sentinel device able to get 2 filters, and with this, and majority of the time, it's successful. If you think about theory point of view, you will say, well,
Can you bring
if
the
you're not
PE up?
used it, that how difficult it will be. But it's, as you saw earlier, when Anu deployed it, it's really very easy to do. Once you have identified the correct anatomy.
Can you bring it up?
Once you have identified the correct anatomy,
Up.
that 90+% of cases you can deploy and
Can you
retrieve.
just talk through how you're retrieving this,
Okay,
please?
now what I did was, if you can show here, initially to deploy this number 3, I had pushed forward, which was a filter. So what I did is, you pull the number 3 back, so the filter is inside. Now that part is done, then you come to number 2. So in number 2, you undo the curve that we had.
It's going to go straight again.
Yeah.
There you go.
So that's good. Now you bring your handles together. Very, very important. They say the handles have to be together. Without these two handles being together, you cannot go to step number 1. So now step number 1 is same. I had pulled it back earlier. Now I'm going to go forward. So your filter is inside. So everything is locked inside now.
And let's see if there's anything in there. That's really what I want to see.
Yeah, microscopically knowing that 90+% of cases in the trial had some debris.
Let's see what you got in
Okay,
there.
make sure you put some.
Maybe the microscopic debris.
Here. Show it to them.
Maybe we need an electron microscope.
Well, let's see.
Do you
And
see?
your anticoagulation was just low-dose heparin here during the procedure. Is that correct?
No, but they cannot see it here.
No, I will. We will
Camera.
open it. Okay. They want to see us opening.
Yeah, they want to see.
Yeah.
Advanced head.
So, Roxana, you know the data very well. How much of this was macroscopic, or how much you need to
it
see
was-
microscopic? Because
It was
Visually.
Visually, it was like 90+%,
So it was
and then
already 90%
99.9%
Yep,
had
90+% you see the visual debris.
something. Yeah. So we should.
No, I think it's all microscopic.
Microscopic, that's it.
No, it's Deepak speaking here. No, the case was masterfully done. There's no arguing with that. But I would just say, though, when we're talking
something
about...
here?
There's got to be something
We found
there.
something in the distal one. See that?
Yeah.
probably
Yeah.
a chunk of calcium from the
A
predilatation.
chunk of calcium,
Yeah,
right?
they
That's why we
actually,
don't
that's
like
what
to
they
do
reported. Many of
predilatation.
them just a big chunk of calcium.
Just hold it there.
But, when we're talking about MRI findings like that, it seems like as a community of interventionalists, we hold data to different standards. Because if you look at the carotid stenting and carotid endarterectomy literature, the filters capture a lot of debris with carotid stenting. Cross-clamping and doing endarterectomy captures almost all the debris, but yet we're concluding that carotid stenting is as good as carotid endarterectomy, despite the fact that carotid endarterectomy is much superior to carotid stenting if MRI-defined lesions that are asymptomatic are the endpoint. So, I'm still not convinced that the MRI findings necessarily translate to clinical events. Having said that, I'd rather not have
I think
abnormal
what
MRIs.
we just saw, though, Deepak, you see that chunk of calcium that is now retrieved. Now, maybe it wouldn't have gone up north, I don't know, but that's pretty impressive. They just showed it.
That we are in the distal filter.
In the
But while
distal
we are
filter.
continuing discussion, I think we let Anu go. We are ready for another case with the
This was
CTO.
a
Yeah.
conscious sedation. We have Menachem, who is our anesthesiologist, who has done a tremendous job in this case. And this was a PERC case, which they will do post-closure with a PERC close. And this is a patient could go either CCU, or I think if everything looks okay, is likely could even go to the floor.
No, telemetry floor, yes.
Telemetry.
We are the separate step-down unit for these intermediate risk patients, and they, basically has worked out very well. Even the staff has been trained to take care of the temporary pacemaker, because that was one of the biggest issue was, because many of the unprotected left main after Impella, everything looks good, because CCU is always full, we send them to the telemetry floor. So they were very well adapted to take care of complex cases. Issue was only the management of the temporary pacemaker. But with the education, we are able to send even patient with a temporary pacemaker to our telemetry floor.
Wonderful.
Yes.
Really, really good. I mean, I think that, when we see that debris, it is compelling, I would say.
I agree with you. It is visually compelling. I feel
Visually,
the
I
same
don't know
way.
what it means.
But I felt the same way about thrombus aspiration and STEMI. In fact, I used to do thrombus aspiration in high risk and STEMI.
And every time you get the material.
Yeah, and I felt good about it. I actually published that end-STEMI thrombus aspiration and circ as a series of images. You can get a lot of thrombus, and it intuitively in that setting feels like it should have worked, but then the large outcome trials didn't confirm that.
So Deepak, one of the arguments is that we don't check thoroughly the patients from the neurological perspective. There are a lot of cognitive changes that we say, okay, the patient was like that before. Maybe this is actually more than what we believe, but I agree that we need more data to see where this should fit.
No, I agree with you. Looking at cognitive function closely before and after would make sense. And if that were favorably influenced, that would be a strong argument.
It's just that it's so hard doing. We did so much work to get cognitive function. And these neurocog batteries of tests are so impossible to do in these elderly patients. Extremely difficult to perform and difficult to. So I think the best is to do the hard endpoint of stroke, and hopefully somebody will do this. Mike?
I think this actually thrombectomy is a very good comparator. I think the problem with the trials was it was always all or nothing, right? Everyone should get thrombectomy, or now no one should get thrombectomy.
Yeah.
When in actuality, I think clearly I pick and choose patients with very high thrombus burden. I use it. Otherwise, I don't. In this case, I think I would have used the Sentinel device because you do have some predictors of clearly some predictors of stroke from the CT scan. I wouldn't use it in probably the majority of patients, but I think it clearly makes sense in that sense to pick and choose based on your common sense.